I could show it to the students. The other modality that we also use is the flow track. It uses an existing radial or a femoral arc line that is attached to a monitoring unit, and it gives all the values that we were just talking about on the monitor. And these values, like I said, if you know to apply, if you start applying them on a day-to-day basis, then it starts making more sense. So what are the flow track parameters? It's just almost the same parameters. It'll tell you the preload parameters, the contractility parameters, your afterload parameters, and your lung water and permeability parameters. Interpretation, it's very user friendly. We like you can see on the screen. I'm sorry, the screen is slightly a little bit unclear, but I'm sure most of you must have seen it. If not, I would advise most of you to have a look at it. It's a very useful system to use. Gives you color coded markings also to know that which of your parameters are in the normal range and which are outside the normal range, and then you can act specifically on those parameters. So stroke volume variation optimization is a reliable indicator of preload responsiveness on controlled ventilated patients with a regular heart rhythm. So in this patient, if you can see, if your volume responsive stroke volume variation is more than 13%, he will respond to the volume challenge, and if it's not more than 13%, he will not. And your normal target, if you look at it, your index should be around between SVI should be between 40 to 50. And if that is there, then you require pressors. If your SVI is low, less than 40, you will require tropes. And if your SVI is more than 50, you require diuretics. So if you look at that, this screen will give you this information, and this decision tree will make it easier for you to manage these kind of patients. This is a chart which compares your PA catheter versus flow track algorithm. What essentially the goals are the same. It's just that the parameters that are available using these newer modalities are much more accurate. And although we do use a PA catheter, we also use the flow track many times, and we ourselves try to compare, because unless you do it yourself, you will not be able to decide what works for you. The flow track references, I quote, although the volume of crystalloids administered during surgery did not differ significantly between the groups, F received 24% more crystalloids and threefold more crystalloids post-operatively. So if you look at the chart below, you will see that the flow track group has received more fluids, and this post-operative fluid balance tended to be more in the group F, which is your flow track group. So it gives you that much of confidence to give the fluids, because as long as you're sure that your pulmonary vascular permeability is fine, and there is no problem or no threat of pulmonary edema, you can give the fluids, because that will definitely improve the patient rather than using inotropes when they are not mandated. So if you look at this table, the comparison of the duration of administration of inotropic/vasopressor after operation, duration of respiratory support, and length of ITU care and hospital stay in different study groups, what this study has said is that, and I quote, that the duration of post-operative respiratory support increased by 36% in group P, which is your PA catheter. However, the duration of ICU stay and hospitalization was not very different. So also, the first point, the incidence of colloid administration trended to be higher in the flow track group. So, like I said, it's more definitive. There is evidence that the respiratory support has reduced by using the flow track, and I think these are obviously subject to evaluation, and that's why I'm not saying that one system is better than the other. What I'm saying is that what is more important, that each one of us starts using these and then making a call for ourselves. So in conclusion, hemodynamic monitoring enables early detection of change in the patient's condition. New techniques provide reasonably good results and are less invasive. However, they require more studies to validate their effectiveness, and these studies have to be patient-specific, they have to be institutional specific, and each one has to actually try them and validate them themselves before they decide to use them. And the last point is the most important. Always correlate the readings / findings with clinical pictures of the patient, the actual clinical picture, in order to provide the best treatment options. Thank you very much.
Thank you,
On
Professor
behalf of
Sagar, for
ACTA
this
Mumbai.
nice discussion. Okay. Now the next speaker is your Dr. Shubhendu Sarkar. I'm inviting you for this topic on this fast-track anesthetic strategies in cardiac setting.
সব কিছু আছে এখানে লাগিয়ে দিতে দেখে আপনার ল্যাপটপটা একটু নামিয়ে নিলে একটু ফোল্ড করে দিলে ভালো হয় আমি তারপরে এখানে রাখি আপনার টাইমারটা আপনি টিভি দেখতে টাইমার কি কেউ মানছে ভাই Very good morning, and thanks organizing committee for inviting me. The one thing I must assure that I will strict myself in time. So 15 minutes, I'll try to finish in 15 minutes. Yeah, this fast tracking, yeah, hi ma'am. The fast tracking in cardiac surgery or the cardiac anesthesia, you can say it's not a very important topic to discuss because it's a topic where we should have a scope of bilateral discussion because it's not only a clinical importance but also some had a little bit of administrative importance also. So we all know from Tera Kya Hoga say something like that, we come to the fast and furious stage, and obviously being an cardiac anesthesiologist or a perioperative physician, this fast tracking strategy regarding the cardiac surgery is concerned. আচ্ছা আমাকে 5 মিনিট আগে থাকতে একবার বলবে যে স্যার আপনার 5 মিনিট সময় আছে না না ওরম বললে হবে না আচ্ছা ঠিক আছে ওকে সো দ্য থিং ইজ it has a bit of administrative importance because right now we are running something, we just going through a tug of war, we need to sit couple of number of time with the administration to find out. So it maybe sounds to be a clinical topic, but ultimately simultaneous to the clinical, it has a bit of more non-clinical importance. So the modern cardiac surgery is faced with the challenges of finding the right balance between the patient's safety and economic restriction. Because we know there are fantabulous things are there. We know even I fortunately has an experience of using more than 3,500 PA catheter, and someone if says to me PA is still the gold standard and till the day I will work it will be the gold standard. Has some a lot of controversy. But if you drag the controversy a bit more, the administrative issue pokes in. So these are the harsh reality of we are going through this. So the fast track approach to the cardiac surgery can be defined as a perioperative process that involves the rapid progress from the preoperative preparation through the surgery until the discharge to the hospital. So now, obviously we cannot put all the patients who are undergoing cardiac surgery in a fast track. The choice and the titration of the short-acting anesthetic drugs, gradually we are having more options even till the Sugamadex has come. We are probably starting a bit a new way of getting more in the fast tracking strategy. The standard surgical procedure, early extubation, reworming and sustained post-operative normothermia, proper pain control, early ambulation, discharge and follow-up after discharge. These are the entire thing that we need to take care of. Obviously, we have some part as a clinician, but we have a lot of part. We are not directly involved, but we have to make it done. Then only you can create the complete cycle for that. The traditional cardiac anesthesia protocol was definitely to start with the high dose narcotic techniques with the longer acting muscle relaxant and mandatory overnight ventilations. We are gradually coming out of this first in the form of early tracheal extubation and prolonged overnight ventilation. If you say that the pendulum between these goes, and obviously in every hour in cardiac anesthesia practice these decisions goes on changing. You cannot make it, but obviously from the preoperative evaluation, if we have a standard protocol, we can at least make it sure that yes, this patient in our clinical experience, if everything goes smooth in our institutional protocol, we can definitely put them in fast tracking. So the standardized surgical procedure, the standardized techniques, these are all comes gradually, and the cost cutting, efficient resource utilization, and the patient comfort, these are the all things you need to understand. So it's not always that fast tracking means we are doing something the cost analytical point, but simultaneously the patient safety is the first and most important, and that's why I'm telling you, don't stick to very harsh, because the days are coming, definitely it will become a standard protocol for all cardiac anesthesia practice, but till now we are gradually going, but in a very diplomatic way. So the fast tracking is the extubation within 6 to 8 hours of the end of the surgery, but many major centers, they even try to make it 1 to 4 hours post-operatively. Don't ask me regarding the on-table extubation. I am deadly against that, because I didn't find any, even a 1% jugglery in making a patient extubated, how simple the cardiac surgical procedure in, then extubating on OT table. And obviously, if you ask me again to the next portion regarding this economical portion, obviously it even doesn't give any economical benefit to the administration also. It's simple as that. So there is also the notion of the ultra fast tracking. So this fast tracking and ultra fast tracking within the first 2 hours and 6 hours, just a time bound tossing. So the benefits of fast tracking. The patient recuperates more rapidly, shortens the period of the critical care, that is the LOS. Psychological boost, obviously we can avoid, particularly the age-old individual who has a very prone to go to some cognitive dysfunction or the ICU psychosis, we can drastically avoid that. Reduce the stress, obviously reduce the stress on the ITU staff itself, and obviously the last and foremost, the golden word is the cost cutting. Reduce requirement of sedative and inotropes, reduces cardiac complications, fewer ventilator associated complications, and reduced wear and tear on the ICU equipments. Obviously, if you say being a senior cardiac anesthesiologist or a perioperative physician, these are the points is really concerned, and some way we are deeply and intricately involved in all these points. Now, the purest person in this world who actually born not to do any mistake, they are always right. They are the cardiac surgeons. Okay. So now these cardiac surgeons who actually, if the heart is bad, but they are good, but the coronaries is bad, but their knives are working, they have to take care some of the things if you want to run a proper fast track protocol. The first one is patient selection. Number 2, optimal surgical correction. Speed and precision. I put these 2 points together. Even in my stage, obviously, even my, if you can say my teacher is sitting in front of me, Poonam madam, I think madam will agree with me a bit, that I usually judge a surgeon, I usually judge my inotropic titration and monitoring standard by seeing how this person opposite the barrier is going to give me trouble. So this speed and precision has to be decided by you. Then you have to put whether this patient is applicable for fast tracking. To him, everything is fast tracking. If possible, he can do the heart transplant, extubate on table, and the evening send the patient for a cup of coffee to establish himself. It's not like that. So the story obviously has a bigger portion, and we also need to convince people like this that, and obviously, the minimizing of the aortic cross clamp time, cardiopulmonary bypass time, it is a bypass procedure, procedure on pump, adequate hemostasis, error-free, MICS, robotics. So now I think these points definitely mainly come under the heading of cardiac surgeons. But we are actually involved. If these criteria somehow with our daily experience comes, we can think this patient is actually growing gradually in the protocol of fast tracking. Role of cardiac anesthesiologist, choice and titration of the drugs, fine-tuning hemodynamics, invasive monitoring, effective pain relief, and obviously the availability of 24/7. This is really a practical importance if you want to professionally and perfectly want to run a protocolized practice of fast tracking in your organization. You doing something 1 or 2 cases a month, that doesn't mean anything. If you are practicing, if you want to practice, you need a qualified cardiac anesthesiologist 24/7 available. Now, it's a teamwork, obviously. Perfusionist, smooth conduct of the CPB, myocardial protection, sustained normothermia, and error-free. I'm not going to the controversy of the word error-free. I don't have much time, only 6 minutes left. But these 3 points, this smooth conduction of the CPB, myocardial protection, and sustained normothermia, you need to be with the side of the perfusionist. Please don't take me otherwise. Pardon if I am wrong. I have seen couple of people, particularly in the junior people I have trained, that they are actually away from the extracorporeal thing. Once the patient goes on pump, they usually go for taking foods and other something waiting outside. They don't see anything what is actually happening. You may have a perfect patient. You may have a perfect patient. You may have a perfect anesthesia practice. You may have a perfect surgeon with a good precision and everything, but your entire fast track protocol will be totally devastated if you don't have to be there for perfect identification of management, these 3 points by our extracorporeal specialist or the perfusionist. Next, the theater technician, nursing staff, you can see everybody gradually, now we are increasing the numbers, they are all comes in the compass of the fast tracking. So the normothermia, arrhythmia prevention, multimodal analgesia, a good hemostasis, a proper monitoring, these are all strategy to facilitate fast tracking. Now following patients are definitely eligible for the fast track. In one word, adult patient, it's an elective case, it's an either CABG or the valve surgery plain, and first time surgery, not redo one, having a good LV function and no recent myocardial infarction and no systemic disease, obviously a big amount of the comorbids. So these are the patients, more or less you can put them in the fast track from the beginning. And 8 independent fast track failure, impaired LV function, acute coronary syndrome within 30 days of surgery, redo surgery, extracardiac arteriopathy if the patient is already on IABP, having a high creatinine, it's an emergency CBG, directly cath lab to the OT, and complex surgery, obviously the combined procedures. I am not going to the details of the anesthesia techniques because every day we are doing all these things. So obviously the muscle relaxation has gradually taken care by the rocuronium instead of the pancuronium bromide. I use etomidate regularly, and remifentanil I haven't used. I use standard fentanyl. And obviously I am very much fond of dexmedetomidine. I am using this in an op-pump procedure particularly. I am using it from 2009 and continuously I am using, getting a very good result, but obviously not all the patients. We have selecting criteria where we are going to give, because this drug I found is really a bit helpful in the fast tracking in the post-operative period. These are the tracheal extubation criteria. Patient responsive and cooperative, negative inspiratory force, vital capacity, PO2, cardiac index, temperature, pH, test tube range, and absence of the uncontrolled dysrhythmia. And these are the CTVS I2 discharge criteria. The important thing is regarding my previous topic, what Dr. Shate has very nicely said about this advanced monitoring. The one portion I am taking, you can say I am borrowing from him, that if we have a good advanced monitoring technique, the criteria for the fast tracking even go very fast for a perioperative physician. I am not telling that we need a PICO technology of getting every patient, we are not funding of the global endoscopic volume and other, but with a thermodilution PA catheter, if we been able to monitor the 2 things, one the patient's what is the cardiac output and the index, forget about the monitor digits, and one blood gas analysis from the pulmonary artery to see the mixed venous oxygen saturation, I think your half of the fast tracking protocol is done in the post-operative period. Okay, so these are the CTVS I2 discharge criteria. The patient is ready to go to the step down area, and in the hospital discharge criteria is the hemodynamically stable, stable rhythm, afebrile, patient able to void and had bowel movement, and patient is independent in ambulating and feeding. See, the last point is the most important for me. I will allow the patient to go home if the patient at least can maintain his or her basic responsibilities without the help of the people. We don't want to send the patients in a stretcher just showing that the LOS has come down. And the many options is available, obviously local infiltration, nerve block, opioids, NSAID, there are all different drugs you can. And fast tracking in the pediatric cardiac surgical patient, I am not going to details into this because there are couple of situations, particularly the absence of the fewer ventilator associated trauma, accidental extubation, laryngotracheal trauma, mucus plug in the ET tube, pulmonary hypertension crisis, Barrett trauma, VIP, these are the all things that comes in the pediatric criteria. But the most important thing what I found that if you say fast tracking, pediatric cardiac surgery, I don't have much experience at all. What I have a bit of experience, obviously an ASD, VSD or the PDA, which is a basic more or less an healthy baby, preoperatively the investigations and the evaluation has done nicely, and particularly this SINT group of people, I tried to extubate these patients within 5 to 6 hours. This is honest confession what I do, what I have done till now. Above that, if you come to the level of cyanotic heart disease of complex repair, even to take a case of the tetralogy of Fallot, we are planning for an extra cardiac shunt in the form of a Ballard-Tushek shunt, BT shunt, or the BD Glenn. We also tried, but if you say I am not very happy and I am not that experienced to comment on this fast tracking in cyanotic heart disease. So obviously we can try by giving, adjusting, reduce the requirement of the sedatives, early embolization, mobilization, ICU discharge, decrease length of stay, reduce cost, parenteral stress. So these are the things, so I am not discussing much about the pediatric. Okay, and these are my literature of the review where I read and obviously I tried to prepare this. So a stable of ART cardiothoracic unit, you need a proper patient selection, you need optimal surgical correction, it is your surgeon's responsibility. Physiology based approach, it's your job. Interaction with surgeon, perfusionists and nursing staff, it's your job. Cardiac anesthesiology is 24/7. Ramkrishna Dever kothay, kormo kore jao pholer asha koro na. Just go on doing work, don't expect any appreciation for the team. Shubho Naboborsho, thank you very much.
Any question please from the audience?
Sir, we disconnect.
Thank you. Professor Poonam Malhotra Kapoor, please. Talk on regional anesthesia in cardiac surgery.
একবার একটু ঠিক করে দেখো ওখান থেকে আসছে কিনা